to talk about transplant as well. Slide, please. Romina, can you just forward the next slide, please? Thank you. So again, we have this slide every time we meet, right there. Oh, there we go. So the goal of this series is to continue to provide scientific and patient-oriented perspective, myeloma features, and biology. We want to keep things open. We do have a schedule for the now for the series going into next year, but we're always open for suggestions. We want to talk about newer treatments that are coming, what's available to everyone in the different provinces. Talk about immunotherapies, how to access clinical trials, etc. And really, the most important, I think, is to provide a forum for you as our stakeholders to ask questions and hopefully have all the information that you need as you and your loved one goes through the journey with multiple myeloma. Slide, please. So Dr. Reese is going to take over now and talk about what the current landscape of myeloma treatment is in Canada. And I'll let Dr. Reese take it away now. Thank you, Dr. Reese.
Yeah, thanks, Suzanne. Thanks, Romina. And please know we appreciate you all taking time out to join this session. And we do want your feedback on the time. You know, we're a big country, several time zones, and we want to make this as convenient as possible. I'm going to talk about our current approach to myeloma, where we've been, and where we are today. And I think many of you are familiar with this kind of approach. There are a couple of things in Canada, just like Europe and Japan and Australia. We make a determination shortly after diagnosis whether we should recommend to an individual a stem cell transplant, or should we offer a different treatment without a stem cell transplant as the first line treatment. You know, there are a number of names for this, and so we all have a common understanding. We refer to this first treatment right after diagnosis as induction. We call it first line treatment. Sometimes we call it upfront treatment. It all means the same thing. It's the treatment we give until it quits working, and then someone experiences their first relapse. And fortunately, in myeloma, the story doesn't end there. We know from our CMRG data that the vast majority of people need and get second-line treatment. It'll hold the disease for a while, then third-line treatment. And now we're in the era where these new drugs that we'll talk about more next time, we know that a huge number of people need good fourth-line treatment. So next slide, please. Now, I'm going to start with talking about what we talk about transplant eligible. So if we see someone in our clinic, how do we decide who goes to a stem cell transplant or who gets the non-transplant treatment? Now, we do use age. And in the jargon, we tend to say physiologic age rather than the number of years, because someone can be a marathon runner at 75, where someone else can be suffering from a range of medical problems, from bad heart disease to dementia. But we do need to be aware that even though someone may be very fit and can have a similar effect on the cancer, transplants are a strong treatment. And after doing this for over 40 years, it's it's very clear that just because our bodies don't heal as well, someone that's 76, I've seen have a transplant, but their recovery, I mean, all the blood tests came to normal, but the energy took a really long time to recover. And, you know, who would want necessarily to spend a year getting their fitness back up from a transplant when there are treatments that don't knock people down? So I think we have an age limit of pretty much 72 years. It's interesting in Europe, particularly France, they have a hard stop at 65. That scares me. But
But Dr. Reese, sorry to interject. It really wasn't so long ago here that we had a hard stop as well. And you know, I had a dear friend many years ago. I don't think you and I have ever talked about her. And this was before I was involved with myeloma at all. And she was living in Perth and was diagnosed with myeloma. And she was 61, where, you know, now that I'm significantly past 61, that seems very young. And there weren't that, this goes many years back, there weren't that many treatment options available. But because of her age, it was a hard stop. She never went to transplant. So, have you found in your practice, since uh, uh, we sort of are looking at chronological or physiological age rather than chronological age, that you know, has that improved sort of survival curves in a way that, you know, people are able to go to transplant even though they're 64 or 69 if they're fit?
yeah, and I think one of the challenges in our healthcare system has been is the government has not put a hard age limit on. But
Oh,
there were times in, at least at Princess Margaret, that we did not have enough resources. We didn't have enough stem cell collection machines. We didn't have enough beds, and we could not accommodate people up to a certain age. So our center has the data for select individuals says you can certainly go up to age 70. When I practiced in the US, there was not an age limit. Now I think there should be because people don't get their fitness back. And we have other treatments, as you'll hear, right now that are quite good, so that not having a transplant today is by no means a curse. But
absolutely.
a lot of this has been due to resource
Yeah.
availability. And
Interesting. Thank you.
we had a time that we had to limit because the waiting list from stem cell collection to a transplant was over 5 months.
Mhm.
We were so backed up. So anyway,
Thank
um,
you.
now the other factor is we don't want people to have another serious illness like a brain tumor. And just as a precaution to keep transplants safe, we do a battery of outpatient tests, screening tests, organ function tests first to make sure we're not missing anything subtle. Now, I think most of us would say if an individual gives us a history that they've been generally healthy and they haven't had heart disease or anything, it's not common we pick something up that says after we meet them, okay, you can't have a transplant. But we sometimes pick up other health problems. And fortunately, much of the time we can fix it ahead of time before the transplant. You don't want to go into the transplant not having done your homework. And a few times a year, we'll do a heart scan or an ECG and we'll say, hey, we think you have coronary artery disease and you're fine now. But if we do a transplant and you get a fever and your heart rate races, because that's what happens with a fever, you know, we don't want to strain your heart. So we work with heart specialists and they'll do what they need to do to fix it. So you kind of get a tune up anyway. We do breathing tests, we double check liver and kidney. And another important thing, since we're a nation of people from other nations where there may be more common tuberculosis or hepatitis, we screen for these things because that period of the transplant, the immune system's weakened, and we don't want these other diseases to wake up. But there's good news. When we do our screening tests, even with hepatitis, we have a liver expert who sees our patients and said, yeah, I'm worried this could flare. We have a pill for you that will suppress the hepatitis so it won't flare. Or occasionally we have to treat for TB, or we can fix things ahead of time. I mean, nowadays we can transplant people with HIV. It's well documented. There's special things we do, but that doesn't increase risk, which is quite, it's cool because it reflects how much the healthcare system's gotten better in general with how to fix the problems we get when we're older. Next slide, please. The next issue is, when do we do the transplant? Oh, this one didn't come through. Okay. Oh, I like this slide. Oh, you found it.
It's a miracle.
Generally, in Canada and most of the world except the US, transplants are done quite routinely after 4 cycles of this induction treatment, first line treatment, because we have to cool off the disease. People come to diagnosis because they're ill. And we have to get their symptoms down. There's a lot of work we have to do first. So this treatment can start while we're preparing to do the transplant. And that we call this then, when transplant is done as part of the first treatment, we call it an upfront transplant. It's not done day one, but it's part of treatment number one, line of therapy number one. Or I use the phrase, transplant is part of first line treatment. And it's been well shown that if you're going to do a transplant, you can do it at diagnosis. You can do it in a second remission. In the old days, it was even done later. But if you want to get the longest bang for your buck, doing a transplant after, in maybe 5 cycles of induction, but after induction gives you the longest benefit from the transplant rather than postponing it. But we look at different things in trying to assess how helpful a cancer treatment is. We look at how each treatment, how long it works to control the disease, but we also, since we have 4 or more lines of treatment, we want to look how long a person lives with all the treatments available. And there are some, but not all, studies that say, if you look at how long someone with myeloma lives, it doesn't seem to make a difference if you do the transplant as the second treatment. But that doesn't tell the whole story, because if someone doesn't have a transplant after the first 4 cycles of induction, it doesn't mean you stop there. The disease will grow right back. It means continuing that induction treatment that means coming into the cancer center for some sort of injections for a total of 8 to 12 months. And then followed by long-term treatment. We don't really call it maintenance if it's not given with the transplant, but it may involve 1 or more agents to suppress the disease. So it's not like
Donnie, Dr. Reese, rather, you've frozen. We can see you, but we can't hear you. What I'll do is I'll continue on until you can get back online. Just looking at making sure that we stay on time. So as Dr. Reese was saying, if a patient does not go to transplant after the first 4, are you there, Dr. Reese? No, first 4 cycles, then they will continue on for 8 to 12 months, and then go on to long-term continuous therapy. There are possible challenges when ASCT is postponed after first relapse. Hopefully, Dr. Reese will be back in a second, but as stem cell transplant may not be possible due to unforeseen circumstances, and life is life, and many things can happen, both medically and within families, and there's many reasons that people might not be able to go to stem cell transplant. And transplant benefit in terms of disease control is shorter than if it is done up front. So we'll just wait before we move on to the next slide to see if.
Can you see me now?
Oh, well, there you are. Welcome
Okay.
back.
It just froze and crashed. I
Yeah,
didn't touch
that's
anything,
fine.
I promise.
That's fine.
So
So I sort of went through this slide, but you can continue on. Thank you.
yeah. So um, not having a transplant doesn't mean you're free. And it there are an old study that shows that the total time on combination chemo with injections is actually shorter if you go to a transplant. Now, there's the side effect of the transplant. And then I've seen in previous years and in the US when we tried sometimes to postpone the transplant until the first recurrence, sometimes things happen and a person can't get the transplant. You can think if someone has a catastrophic stroke, I mean, it's not a dime a dozen, but it happens. Or sometimes the disease is bonfire. We can't get it back under control. So a person misses that piece of the choices of treatment. And as I said, how long the transplant suppresses the disease is clearly shorter than if it's done up front. And I don't want to ask my patient to have a transplant with its recovery time as second treatment if it's only going to give them a year. It takes several weeks or months to get your strength back. And I think how that's presented, that patients need that information in addition to this overall survival may be the same. Next slide, please. So what are some of the nuts and bolts of the transplant? For until really the last year or so, our Canadian approach has been to give a combination called Cyborg-D, cyclophosphamide, bortezomib, Velcade, and Dex, stem cell collection, transplant, and then at day 100, start low-dose lenalidomide or Revlimid maintenance and give it as long as it works. And we have looked at our 15-year experience in almost 4,000 patients. That's one of the kinds of activities that CMRG does because we don't know how we did. Now, this is real world data. This is not a study. This includes people on dialysis, people that are any age, and the information was very helpful. Very few people died of transplant-related complications. And lenalidomide maintenance clearly has improved how long the transplant controlled the disease. So a transplant, even though we call it a transplant, it actually has 3 parts: induction, stomp on the disease with the transplant, and then mop up anything left over, try to keep the lid on with maintenance. That's one treatment, even though there are lots of drugs. Now, there's recent research that shows that RVD, lenalidomide, Velcade, Dex, induction, stem cell collection, transplant, lenalidomide maintenance, in a trial is better than Cyborg-D. And it looks like, again, this isn't real world. These were patients that were very healthy, had good blood counts, et cetera. Looks like it may give another 1.5 years to the previous findings with Cyborg-D. And now RVD is funded in all provinces, finally. Um, and it's important to note repeatedly that everyone is different. And sometimes we use a different maintenance. Sometimes we use a different induction to tailor it to a patient. And some examples are we don't use Revlimid or lenalidomide maintenance if someone if someone has kidney problems. Uh, there's a small risk of secondary cancers with any myeloma treatment, and we worry about with Revlimid maintenance. So we may not, if someone's had prostate cancer or breast cancer, we may not want to give Revlimid maintenance. We may want to give something else. Next slide, please. So it's very individualized. Now, this slide looks complicated. To me, it's not, but I can appreciate it is. On the left, this is our 15-year analysis. And this is the kind of work we do at CMRG to see how we're doing and define gaps. Where do we need to do better? So this is CyBOR-D, a transplant, and the red line shows how long the disease was controlled with Lin maintenance, and the blue line shows when we didn't have maintenance. And what this slide tells us is the control of the myeloma lasted twice as long with maintenance than no maintenance. Now you can still, you hopefully can see that there are people without maintenance that are doing very well at 14 years. So, this tells us how a group of 3,800 patients does. It doesn't tell you what treatment you should have. And what was very exciting to me is when we looked at this real world experience, and there's room for improvement. We're working on it. But the median survival of our Canadians living with myeloma, and that means half people longer, half people shorter, was over 13 years. Now, for a country, that was a good starting point compared to when I first came to Princess Margaret. Now,
Dr. Reese, sorry, can I just jump in? I'm sitting here thinking about the previous slide. We don't need to go back a slide, but the idea of secondary cancers. And one of the things that I ran into when I was working at Princess Margaret, and patients would see me leading up to transplant when they were being in having induction, and we were managing symptoms, etc. And then they went to transplant, and then they expressed to me that they were really, really fearful of being on any sort of maintenance because of this idea of secondary cancers. And I think it's really, really important for everybody online who's either has myeloma or has someone that they love has myeloma to really understand that any human being that has had a previous cancer that is being treated is at risk for a secondary cancer. That's just the way it is. And what I would say to people is, if there's an increased chance of having a basal cell carcinoma, which is a very treatable skin cancer, that risk to me is certainly much better than having the risk of the myeloma returning earlier than later. So I think it's very, very important for prescribers and hematologists and everybody on the team to really make sure that patients really understand that yes, there is a risk, but this is the risk. It's not, I had some patients think, well, I'm going to end up with terminal lung cancer because now they're suggesting I'm going on to lenalidomide or another maintenance drug. So, if you, I think it's very, very important that patients and families ask those questions like, what does that mean, risk of secondary cancer? Because it was my experience that a lot of patients and family members really had it a little bit, skewed in their brain about how dangerous maintenance was.
Yeah, I think that's an excellent point, and I think it's important not to sweep it under the carpet.
Yeah.
A lot of and it's a very slight increase. Just having myeloma with no treatment increases the risk.
Yeah.
Other non-transplant regimens carry a small risk in certain settings, not all. But some of these were skin cancers, and you can show data, and multiple groups have done this, that many cancers are treatable. not only skin cancer, no one wants to go through this again, but if you look at people's reason they passed away, it's mostly the myeloma
Yeah,
rather than another malignancy.
yeah,
So, but all this needs to be discussed with people. And when we looked at our Canadian analysis, a very low risk of secondary cancers, which was reassuring.
yeah,
So, determination is the trial that showed it wasn't RVD transplant, Lin maintenance until progression, that it was compared with RVD alone and then Lin maintenance to progression. So it looked at things differently. And again, it showed that your longest remission was when you did the transplant at the beginning, didn't save it until the disease recurred. And that's consistent. And with RVD and a transplant, and maintenance, the control of myeloma was a bit under 2 years longer with upfront transplant. And we expect, I mean, these people have not been followed 15 years like our Canadian cohort. We expect people to live longer. Now, also, this is not the whole story. We have better relapse treatments too. So this is just a snapshot of what we can learn about the first treatment for people who can and decide to go to a transplant. Next slide, please. So I'm going to turn it over to Suzanne because she is part of the team. She's worked in our outpatient transplant day hospital, many at PMH. We to deal with the numbers of patients and not have people waiting 5 months after stem cells have been collected to get their transplant when they could relapse and they're on chemo we would normally give. We really try to do these as an outpatient. It's been well shown that it's just as safe, but it's a different patient experience. And Suzanne's worked with people in this setting and then after they're back in the clinics from the day hospital. So I'll turn it to her to talk about her understanding of the patient experience.
Thanks, Dr. Reese. Yes, as Dr. Reese mentioned it, over the past few years, more and more centers are doing outpatient stem cell transplants, and we'll chat about that with great success. So, as Dr. Reese was saying, people are diagnosed and they have their induction, and then it goes on to have their stem cells collected. And in the next few slides, we'll look at each of these areas of the transplant experience in more detail. So, first stem cells are collected and then it is processed at the lab. The blood, the stem cells, or rarely bone marrow. There's not a lot of patients that actually have a bone marrow transplant anymore. It's generally stem cell transplant. These are frozen to preserve the cells or the marrow, and then the patient's actual stem cells are reinfused after being thawed. Important to understand that an autologous stem cell transplant is quite different than an allogeneic stem cell transplant. In myeloma patients are having their own stem cells reinfused, where in people that are having an allogeneic stem cell transplant, if such as leukemia, they are having donor stem cells infused. Auto or autologous stem cell transplants tend to be a little bit easier to tolerate than the allo transplant, but it certainly is. It is an undertaking for patients and families. And on the previous slide, the last bit was the what is referred to as high dose chemotherapy. And I want to say very, very clearly that I had many, many patients feel very, very stressed about this high dose chemo, and we're quite frightened about the term high dose chemo. And the way I always explain it is it's just true chemotherapy. It's old school chemotherapy that I was used to giving as a young nurse, and had the side effects that are common with true chemotherapy. So we'll talk a little bit about that. So mobilization. So we'll talk a little bit here in this slide about stem cell collection. We first of all have to mobilize the cells. And what happens if we give a medication called GCSF, and it has the bone marrow produce become very hyperactive and produce more and more of these really important stem cells. In most cases, just using GCSF is effective. There are some patients that their stem cells are a little bit more stubborn, and there is another medication that can be used in the collection lab called Plixafor, and they will get in touch with the ordering hematologist if the team at the collection lab or the collection area feels that they need to use it. So the collection is done using a collection machine. It's called an apheresis machine. It's sort of like many people are familiar about what dialysis is, in the idea that you take the blood out and you clean the blood and you put the blood back in. And that is sort of on a very sort of simple understanding of what happens is blood is taken out of the patient, and it goes through this apheresis machine, and the stem cells are removed from the blood, and the blood then is returned to the patient. We want to collect enough cells for 2 transplants, because we know that many patients, if they have if the stem cell transplant is successful, meaning they've had so many months after their stem cell reinfusion where their disease has been in a decent remission, they will likely have the opportunity to go through a second autologous stem cell transplant. Uh,
May
Slide,
I,
please. Yes, absolutely.
as I barge in? I
Yeah, we
think
work as a
it's
team.
important. We use the term, we throw the term stem cell out like anything. What are stem cells?
Mm.
They are mainly live in the marrow, and they're seed cells. There are not very many of them in the marrow, but they're the ones that continuously replant our marrow as we go through life. So our bone marrow makes all the blood cells, they go out in the bloodstream, and then they die. And they have to be replaced. So this is the granddaddy cell. It's the seed cell. There are not very many of them in the blood under normal circumstances. So if we hook someone up to that machine and collect over 6 hours without giving GCSF or Plofexafor, we'd have to do a stem cell collection every day for 10, 12 days, and we might or might not get enough to freeze and use as a transplant. So we have to give this mobilization treatment to stimulate the bone marrow, push those stem cells, those seed cells out so we can collect them in 1 or 2 settings. Thank
Thanks,
you.
Dr. Reese. We are a team. We do interrupt each other for good reason. Slide, please. So after these very valuable stem cells are collected, that's when these cells go to the lab and they're processed, and they're frozen in a special solution, and to keep them alive. And interesting, the solution that they're frozen in, patients will tell us when the stem cells are being reinfused, they have this sort of taste in the back of their throat. And it's often referred, and I don't know if people even eat creamed corn anymore, but they get this sort of funky taste in their back of their throat, and reminding them of when their mother forced them to eat creamed corn in the 60s.
I,
So
I
what's
have to
that?
give you a vignette when you're done.
Okay. Slide, please.
So that magic substance is called DMSO that smells and tastes so weird. So normally if we froze your cells and you thawed them out, they would just crumble. So that protecting substance is called DMSO, and we get rid of it by breathing it out. It keeps cells alive while frozen. Some of you may remember Howard Hughes, the famous eccentric guy that was a pilot, very wealthy, recluse. When he passed away, he had his body frozen in DMSO. So when they find a cure for death, I suppose he's going to be thought out.
Oh, interesting. I hope they cut his nails though before they thaw him out.
But I found it's fascinating because this is how they freeze sperm for, to keep that alive. So it's a remarkable substance. Anyway,
Interesting.
sorry to interrupt.
Oh no, that's I didn't know not I did not know about that. Especially the Howard Hughes thing. So we mentioned and Dr. Reese said talked about we do transplants both as inpatient or outpatient. There are certainly reasons that patients will need to be admitted for their transplant. It may be that they don't have supports at home. A patient, at least at Princess Margaret, needs to be within a certain area of Princess Margaret in case the patient becomes unwell. They need to be within a certain driving distance to get down to the emergency department should something happen overnight. There may be psychosocial reasons that the patient needs to be admitted. They live in a shelter or they have family members that live with them that aren't well themselves. But the outpatient day hospital at Princess Margaret, I was very privileged to be involved when it was first opened. And patients have done remarkably well. I think there's something to be said about sleeping in your own bed with your own pillow and your own duvet and being in your comfortable house and having the food that you enjoy and having your cat on your lap or whatever it is that makes you happy, being admitted to hospital, even though, and I can speak, I've worked at a number of different hospitals. Staff are generally kind and devoted, but it's noisy and things are going on and there's bells ringing in the night and the nurse comes in every hour to see how you're doing, so you don't sleep well. So patients that have needed to be an outpatient or have had the opportunity rather to be an outpatient to get their transplant as an outpatient have done very, very well. At Princess Margaret, and I'm sure it's the same in other organizations, that if patients are having their transplant, follow up as an outpatient. If they become ill, there are beds available to be directly admitted to the inpatient unit should they have a fever or other challenges such as pain control, etc. So again, the outpatient area has been very successful. So again, the patient is given this high dose chemotherapy. Again, don't be frightened with the term high dose. I'm so old at this point that when I first started nursing and everybody with any sort of cancer diagnosis got true chemotherapy where your hair fell out and you vomited constantly and your fingernails fell out and you were a skeleton, where things have gone. We've come so far in the world of cancer medicine that the treatments that patients receive, both in myeloma and in other disease sites, are so much more tolerable. So it's one dose of chemotherapy. And yes, people do lose their hair. It does grow back, and sometimes it grows back more fabulous than before. And the side effects are very, very manageable, and I'm going to talk about that in another couple of slides. This chemotherapy can't tell the difference between the normal cells and the myeloma cells. So that's why our patients lose their hair and feel unwell, because that's what old school chemotherapy did. It just went in like gangbusters and killed everything in its path to try and eradicate the cancer cells. And that's why people got so sick. So then the stem cells that the patient, went to have collected are now reinfused. And those stem cells are reinfused to replace the normal marrow cells. So now we wait until the new infused marrow stem cells start to take over. The normal blood counts would not grow back for a very long time if we didn't reinfuse those stem cells. So it sounds quite daunting and frightening often for patients to think like I'm having this transplant, but it's very well tolerated. It's not a walk in the park. I mean, you don't feel marvelous, but it is very well tolerated, even the high dose chemotherapy. Slide, please. Other way.
No, oh yeah.
Yeah.
Oh no, I think this goes back. We've collected the stem cells. I threw in the
Oh,
high
right.
dose
Oh,
chemo.
thank you.
Yeah,
Yeah,
it's a little out of sequence. I apologize.
that's okay. That's okay. So as mentioned, the stem cells are they're actually brought to the bedside or the chair side, and they're
Oh, no,
thawed right.
this is where we're collecting them and freezing them. So while the patient is getting the high dose chemo, this has already happened from those collected stem cells. I'm sorry, I got ahead of myself with the high dose chemo. So this is what's happening right before the high dose chemo.
That's okay.
Point
Slide,
noted.
please.
No, we're
Nope.
freezing them in DMSO and putting them under liquid nitrogen at a very low temperature. Now, patients had their high dose chemo. You can give the stem cells back we give it back the next day after the high dose chemo.
Absolutely. And sometimes there's 2 bags of stem cells, and sometimes there's 8 bags of stem cells. And it's again very well tolerated. Other than sometimes the sort of weird taste and smell, but patients really don't find it difficult at all. During the stem cell reinfusion, there'll be a registered nurse that is continuously overseeing the patient, monitoring vital signs, and ensuring that the patient is feeling well. Slide, please. So, patient has had their transplant, and whether they are a patient who has been admitted to hospital or has had a stem cell transplant as an outpatient, the first couple of weeks, uh, depending on age, sometimes depending on how robust the patient was going into the transplant, all of this will sort of make the recover depend that will be how the patient recovers. I think the first and foremost, though, is that patients really need to be kind to themselves and really understand that it's your body has been through a huge ordeal, and people need to be patient while they recover slowly. Um, as far as medications go, very often the medications the patient was on leading up to transplant will be the same. There certainly may be some adjustments, but the team will be on top of that. There may be some additional medications that the patient will need. Um, one of the one of the side effects of this high dose chemotherapy is mucositis. And mucositis is, if you think of your worst sore throat you ever had and sort of multiply it by 10, that's how mucositis has been described to me. We use opioids or narcotics to manage mucositis because it can be very, very painful. And also, something as simple as gargling with baking soda and water can relieve uh, the pain of mucositis. Yes,
Do you
Dr.
want to
Reese.
do you want to mention ice?
Yes, I was just going to. Thank you.
Okay, we think a lot.
One of the things that I found as a nurse practitioner when we opened the day hospital, when you have your stem cells infused in the when you're having your chemotherapy rather. As an inpatient, what happens is the nurse hangs your chemotherapy and then she gets called out of the room or he gets called out of the room. When you're in the day hospital, you're sitting in front of the nursing station and the nurses have a little bit more control about what's going on. One of the things that we know without a doubt, and it's been scientifically proven, that if patients are sucking on ice during chemotherapy infusion, it reduces the instances of mucositis significantly. So the patients that had their chemotherapy as an inpatient who didn't necessarily have a nurse sort of nagging at them continuously to stop talking and suck on your ice. Whereas in the day hospital, they were right in front of them. We really found that the inpatients had more instances of mucositis than the outpatient population. And it's because, and I'm not a scientist like Dr. Reese, but it's simple in my mind, and I do work by the keep it simple, stupid. Is that when something's very cold, everything gets smaller, right? And we know that. So those cells in our throat, in our upper esophagus, are not letting the chemotherapy in as much as if they weren't. That area wasn't very, very cold. So you suck on ice, and when the ice cube is small enough to swallow, and then you fill your mouth again and suck on that ice and keep it as cold as possible. It's the same idea as when you see, for instance, if you're in your cancer center and you see women walking around with what was referred to as an ice cap, and what that is a cap that is full of ice in hopes that they won't lose as much of their hair because those cells in the hair follicles are constricted. So don't be surprised if you have a transplant and you've got a nurse harping at you to suck on ice. Next slide, please. So post-transplant course is different for everybody. And again, I'll reiterate that first and foremost, be kind to yourself, take advantage of some quiet time, read a book you've been putting off, or watch something fabulous and tacky on your laptop to keep your mind busy, because it does take a little while to recover. And the first couple of weeks are certainly the most challenging. Over the first 4 or 5 days after transplant, blood counts will drop. So your hemoglobin will drop, your white count will drop, platelets can drop, and that's why patients are given prophylactic or preventative antibiotics, because we know that the immune system is compromised at this point. Energy and appetite is going to decrease for everybody, and it will come back. And we know that food and love in many cultures is really intertwined, and so it's very challenging for family members who are so worried because their loved one who's had a transplant just isn't hungry, and they're trying to feed them, and you just can't eat. You just don't feel like it, and especially if you've had some mucositis. We talked about the sore throat. There may be some diarrhea because the chemotherapy affects from the tip of the tongue right through to the bum. So the whole GI tract can be affected by the chemotherapy. So there may be some loose stools, which is easily managed with medication. Uh, I don't really fret if patients aren't eating, but we really, really, really need to encourage to drink fluids. Even water may taste off, but any sort of fluids that patients can get down, mostly fluids that won't irritate the gut. You don't want to be drinking a lot of juice because, that can make the diarrhea worse, etc. At day 5 after transplant, this is when the counts are at the very, very lowest. And this is where we monitor patients for fever. If you're an outpatient during a transplant, you are told to check your temperature at home very often, especially if feeling unwell. If patients get rigors, feeling chilly and having shakes, we need them to just check for to see what their temperature is. And that patient will have instructions from their team of what to do in that situation. At Princess Margaret, there's a phone number that they call, and they will speak to who is ever on call for transplant, and that person will make the decision whether the patient should be directly admitted for IV antibiotics, or depending if it's already 5 in the morning, then they will speak with the nurse practitioners that work in the transplant center or day hospital to say this patient is coming in because they've had a fever. It's not unusual to need antibiotics after a stem cell transplant. It's nothing to be alarmed about. It's very, very common, and it's because we're so proactive that people will do well. Patients often will need a blood transfusion, sometimes platelets, and it's only because it's taking a while for their own counts to recover. So, as Dr. Reese said, if you're a 42-year-old and you're very fit, your bone marrow is generally fitter than if you're 65 or 75. It might take a little bit longer for these counts to recover. So don't be alarmed if your loved one or you need a blood transfusion or a platelet infusion. These are all temporary measures and very, very common. After about,
Can I
go
add a
ahead.
word? I think it's important that people know that we don't give any extra transfusions. There are
No,
very
yeah.
strict criteria. When I first started and did leukemia care many years ago, we would keep platelet counts over 50. Then it was 20. Now it's pretty much 10, except if it's right before the weekend and we know the counts are going to go down, and that's we're before they're going to come up, we may go in, but we don't give any extra transfusions. And same thing with hemoglobin. We used to keep the hemoglobin over 100, then it was 90, now it was 80. Sometimes it's a little lower. People aren't going out and playing basketball and needing more oxygen. So the blood supply is quite safe, but we don't give any extra transfusions. For one thing, it's a precious resource, and, there are shortages. But I think that's important to know, that each transfusion has to be justified.
And I think it's also important, thanks, Dr. Reese. I think it's also important to know that if we look at each patient individually and each case individually. For instance, some people feel quite well with a hemoglobin of 80, and then other patients, they can barely lift their head. So it's very, very individualized, but certainly it's not willy-nilly, and it shouldn't be. We don't want patients looking at what their blood counts are and and making the assumption that they need a transfusion of blood or platelets. So blood counts generally require about 12 days after stem cells are reinfused. So it's really only this 1 week period where counts are very, very low. And remember, when counts are low, that's when the patient will be at a higher risk for infection, and we'll talk about that. We continually talk about the importance of infection control. Um, Energy and appetite will slowly recover. It's different in everybody. And again, be kind to yourself and know that, these things do take time, and it's different for everybody. Generally, the patient will be seen back in clinic with their hematologist at about day 100 to discuss maintenance therapy and what happens after that. One of the things that Dr. Reese and I have talked about is the it's a little bit of a psychological letdown when treatment, and there's been so much attention with treatment, when a cancer patient all of a sudden is sort of uh, let loose, if you may. So you've had your transplant, you're doing well, you're discharged, and then you're not seeing anybody for 100 days or so. And it can be pretty frightening because, as long as you're going to the clinic, whether it be a weekly basis or every 2 weeks or 3 weeks, there's a sense of feeling safe that if, they're really staying on top of what's going on with me as a patient. So the fact that we sort of discharge patients after their counts have recovered and they're not on any medication for their cancer, they're certainly on their other medications. It can be rather disconcerting to patients and families where that sort of support system isn't there for them. So, that we always encourage people to keep lines of communication all open. And if that is something that you as a patient or family member feels really anxious about, talk to the team. You'll have that reassurance of what fail safes are in place, and et cetera, et cetera. So don't be too distressed when you find out that you don't have to go and see the doctor now for the next 3 months, because it is quite shocking. Slide, please. So back to real symptom management, and again, patients are quite surprised at how really that the transplant isn't nearly as difficult as they thought it was going to be. If I wasn't in the business, so to speak, and I was told that I needed a stem cell transplant, that sounds like science fiction, and it's really, really scary. And once the transplant is done, especially after the first 5 days or so, have gone by, patients saying, it really wasn't as bad as I anticipated. I really didn't feel that sick after the chemo. I really felt really supported. The nurses gave me all of the medication I needed to make sure that my any symptoms was having were mitigated. So occasionally there's some nausea and vomiting. It's pretty rare in this particular instance with auto transplant. We have very good anti-nausea or antiemetics. The trick with dealing with nausea, you really have to understand what's causing the underlying nausea. So even though everybody knows what Gravol is, it's, Gravol is not necessarily what we give. But again, our nurses are highly educated, and they have all of the orders ready for them from the physicians and the nurse practitioners. There may be some changes in bowel habits. As mentioned, the chemotherapy can affect the gut. Often diarrhea, it'll doesn't last long. And then on the other hand, some people do get constipated. But again, these things are well managed. It's really, really important that the patient shares what's going on. Fatigue. Um, any of my colleagues will tell you that one of our real bugaboos in cancer medicine is there is no magic pill for fatigue. There just isn't. There's been lots of research done and lots of ideas over the years about how to manage fatigue. You know, if the fatigue is really related to extremely low hemoglobins that are hemoglobin that has, been over a period of time, transfusions may be ordered, but often it isn't related to low hemoglobin. It's just the fatigue of going through this ordeal. You know, when you think about it, from the time you find out you have multiple myeloma to the time you're finished transplant, you know, what a huge deal that 6 months has been. And so, you're just plain worn out. So, remember that fatigue, that overbearing feeling of fatigue, will resolve eventually. It's very important to rest. I mean, the old thing, rest, sleep when the baby sleeps. It's really sort of the same. Rest whenever you have the opportunity. Make sure that you've had discussions with the team, with your family members, that even though you look pretty good and you're finished your treatment, that it might take many months before you're feeling well enough to get back to your regular activities, which include often, housekeeping and shopping and sexual activity, and it's hard for our loved ones to really understand that when the patient's looking pretty good, but just saying, like, I just want to lie down. It will get better. Conserving energy is really important. I always say, conserve the energy you have for fun things, with, seeing your family, playing with your grandchildren, seeing friends, whatever makes you happy, and leave the cleaning to other people, if possible.
This,
Generalize. Go ahead.
I'm sorry, this is a
Oh, sorry.
subject near and dear to my
Yeah.
heart because I've had to learn over the years, and this is not necessarily 2 weeks after a transplant. It may be 4 or 6 weeks. I
Yep.
always have to bite my tongue when people come to clinic because I'm so excited. You look so good. And people told me many years ago, it says, Doc, that undercuts how I really feel. I don't feel really good.
Yeah.
But, and that's why it's important to stay in touch with your loved one. Because if you look good, that's good. But why aren't you taking out the trash every day and helping the kids with their homework? Because you look so good, it must be good. And of course, your loved ones are so excited and relieved you look good. But people cannot force their body to do what it isn't ready to do. And it's often a very stressful time on relationships because this has been now 6, 7 months into this diagnosis and treatment. And, it's we all need each other. We work as a family unit and we all have different jobs. And for one person to have to take all that on, watch their loved one, the patient, go through this. Well, they finally look good. Can't you please help me with all of these things that are, and of course, when we're fatigued, you look at survival instinct. What's the first thing our bodies give up? It's sexual interest. That's not necessary for survival. And that will come, but people don't want to talk to their doctor, and it's a source of stress. So I think, it's very, and then there's and again, this is not 2 weeks post-transplant, but often closer to maintenance discussion. It's when people come to clinics, and now what? I've been working so hard to get this transplant. I was terrified. I survived. Now what? I'm not seeing the doctor for a while. I mean, I look good. Am I supposed to go back to work? I don't feel, I mean, people are very bewildered. And
Hmm.
they realize now that they're released from this intensive care, is what are they supposed to do with their life? And things have changed. And when we lose our old life the way like it was, we get sad.
Yeah.
So I can't tell you how many times I have someone coming into, big old truck driver, no offense, guys, come in at day 70 in the office, and I don't say you look so good anymore. I say, how do you feel? And the tears come.
Yeah.
I don't know why I'm so sad. Everyone says I should be so happy. It's over. Well, it's not over.
Yeah.
And it's different. And people have to grieve their old life loss, acknowledge it, and then people move on. But who would, if you see a patient at diagnosis and say, when you recover from your transplant, you may feel very blue.
Yeah.
What? It'll be over. So I think just acknowledging this, it seems to be very helpful, that is part of the recovery.
Yeah. And
And go ahead, Suzanne.
oh, sorry, and when I'm giving a talk in May, and we'll talk more about that, because I think, Dr. Reese is a very, very, very unique physician, and is certainly more instinctive and empathetic than many other physicians. And I'm not doctor trashing by any means, but it's very, very important that people really, really understand that this is a big deal. Going through 6, 7 months of treatment and transplant, and then still feeling this incredible fatigue, and we'll talk about depression in May, and how common it is in myeloma patients, and in cancer patients in general. That it isn't all about and not to diminish the importance of all these wonderful treatment options available, but there are so many other things that patients and family members go through when they have any sort of devastating diagnosis, and patients are very, very lucky if they have a doctor like Dr. Reese, who really, really understands those things. So shout out to her.
I
um,
don't really understand. I haven't been there,
yeah,
but I've
well,
watched it so many
yeah.
times
Well,
that
we have empathy. We try and have as much empathy as possible. The generalized malaise with aches and pains often can be related to a bit of a depressive period coming, landing on the patient. And again, we'll talk about that at a further seminar. But sometimes just plain Tylenol or acetaminophen will help. Of course, before taking any over-the-counter medication, you want to check with your team. Generally, acetaminophen, Tylenol products are very, very safe. Of course, we never use NSAIDs as myeloma patients, such as Motrin or Advil or naproxen. We want to avoid NSAIDs at all costs, because those drugs are metabolized through the kidneys. And in previous seminars, we've talked about how myeloma loves the kidneys. Often patients that have been taking opioids for pain leading up to their transplant, because they've had a lot of bony involvement, or they've got a lot of other reasons to have significant pain issues, will likely continue on with opioids, for at least the near future. And again, we're going to talk about opioids and the use of opioids in the spring, in May. But we want to use whatever we can use from a pharmacological point of view to ensure good quality of life. Managing diarrhea, managing nausea, managing pain, managing depression, whatever it might be, we're going to try and find the right medication for what you're experiencing. And sometimes the first medication that's prescribed may not be effective. Everybody responds to things differently. So, if your physician or nurse practitioner prescribes a medication for any of these symptoms and it just isn't doing the trick, let them know and say, well, I felt a little bit better, but I still don't feel that great, because, things work differently in different people. There's lots of pain medication, and some work very well in some of the population and don't do anything for others. So never ever lose that the communication with your team. Where oral intake may not be optimal, and that may last for quite a long time. Um, Again, just to reiterate, that any fever needs to be reported to the team. Make sure that the patient and the patient's family knows what the process is in your particular with your particular team. If there is a fever, is there a phone number? Do you go right to emerge if your fever is above 38 or 38.3? Because we want to get on top of fevers if they're related to infection as soon as possible. Infection can still be a challenge even after counts have recovered, but these are treatable. Slide, please.
One
Yeah.
other point, we often leave in the Hickman catheter or the
Good point.
PICC line for a bit, just to be sure people aren't going to need like intravenous fluids at home to subsidize what until people's normal drinking is available. And just having that silastic tube in, a fever has to be treated because those lines are a lifesaver. They save your veins,
Yeah.
but they can get infected and you have to give IV antibiotics. And a chill, a hard shaking chill, means the same as a fever. If
Yeah.
someone comes to me and says, I had a hard shaking chill, yes, take your temperature. I don't really care what it is. If you have a line in, you need IV antibiotics till we sort it out. And, we may have to pull the line, we may not, but and line infections, are the downside of having those lines in, and that's just good management.
Just keeping an eye on time. Thank you. Next
Oh.
slide. So as mentioned, Dr. Reese and I could talk for 5 hours here and at least entertain each other, but we want to be, aware of the time for you all. Again, I mentioned that fluids, especially water, is the most important. It often, not often, but it can be quite common for taste to be off for weeks to months. People say, I've always loved such and such, and now I can't stand it. Again, patience is, it really is something that you have to remind yourself that this will get better. IV hydration may be required. We don't want. We really, really want to ensure that patients don't get dehydrated, as Dr. Reese mentioned, and thank you, Dr. Reese. Often we leave in the indwelling PICC line or Hickman line for easy access. And so we can give hydration at home through the home care programs, and people don't really understand that, or aren't aware necessarily that when you are dehydrated, you can feel really lousy. And there's a saying in nursing, I don't know if it's the same in medicine, but the old song, what a difference a day makes. Nurses will sing what a difference a leader makes, because patients will arrive and emerge, or will, be post-operative and just be not doing well. And we hook up a bag of normal saline. And by the time that saline is through, they're a completely different person. They feel better. Their energy is better. Their everything. The other thing to note that I didn't put on the slide is when we are dehydrated as mammals, and this is true of all mammals, you would think that the brain would make us want to drink more, but in actual fact, when you become dehydrated, we stop drinking. Our thirst is gone. We don't get thirsty when we're dehydrated. So people often say, "Well, I wasn't thirsty." And then, we'll do our assessment and say, "Well, you're extremely dehydrated." So be aware of that. You've seen me drinking my water. I'm not ill, but water is it really is so important for everybody, whether they're post transplant or not. So again, the communication with your team. We're often, as patients, we're not um, we're not always the best judge of what we need. And Dr. Reese will say that about me, that I'm very, very stubborn when I'm not well, and I'm not, I don't to make the best decisions for myself. So if your loved one says, I think we need to call the team, I don't think you're drinking enough, let them do that, because we're not always the best judge of our own health.
I think
Slide.
another
Go ahead.
point is, I don't know why, but right after a transplant, the body needs more fluids. At least 2 or ideally 3 liters a day. Now, who drinks 3 liters a day of water under normal circumstances? And so that I must be have to do with all the work the body's doing. And another thing with dehydration, we find that when people stand up, they may get dizzy. They don't have enough fluid in their tank. Their body's a tank. And that is a sign that people need more fluids. Even if you're already drinking 1.5 liters a day, you need so much more for the first few weeks after transplant. The good news is that does not last forever, and eventually people will be able, usually, to go to their comfort level. But people need more fluids. They're not thirsty. They can get dehydrated and feel like garbage, but they can also get dizzy when they stand up. That's why we do sitting and standing blood pressures. It's a real key for how dehydrated someone is. And we don't want someone to stand up, get dizzy, pass out, and fall. Falling is our pet peeve. And it can,
Absolutely.
so that's why,
Dr. Reese, it's 20 after 3. We need to keep moving here.
yeah. Okay, next slide.
Please.
Then we'll decide when to close. Next slide, please. Um, this, this, um, this is where we've been and where we are today with a transplant, RVD, transplant, limb maintenance until progression. But the world has already changed quickly. And now there is better induction before transplant by adding a drug like daratumumab, or you can add isatuximab. There are ways to make maintenance control the disease longer with adding a monoclonal antibody like daratumumab or isatuximab. And there is a whole world of adding other immune treatments beside what we call these CD38 antibodies like daratumumab and isatuximab before or after a transplant. And this is revolutionizing the transplant. This is a bit of a teaser because it's a whole another subject, and we're already way over time. But this is tremendously important. We want you all to know where the field's going, where we're advocating to get these newer treatments into Canada as standard of care, as well as many trials as possible to get these in. So please stay tuned for the next seminar, which is going to deal with immunotherapy in different settings. Next slide, please. I am wondering, since we're so over, I was going to talk about initial therapy in transplant ineligible because tremendous progress has been made there, but I'm afraid we won't have time for questions. I wonder if we should move this to the next session.
I
And
think that's I think that's a great idea. We can sort of regroup and I think that's a great idea, Dr. Reese.
Yeah, because I mean, we appreciate your attention. As you can tell, we both get very carried away and enthusiastic in trying to share all this, and then time's up.
Yeah.
But we're way over, and I can't blame it all on my system crashing. So why don't we open it up for questions?
Yes, absolutely. We still have 26 people online. Thank you to everybody that has stayed with us. If we can just forward the slides a little bit, Ramina, and I'll just tell you just again and again and again and one back, sorry. So we'll open up. There is the chat box, but we'd love to hear if you can put your hand up if you have a question, and then you can open your mic. So next in May, I'm going to be, as mentioned, talking about symptom management and supportive care, and then in next month, Dr. Reese will be presenting primarily Dr. Reese on the newest treatment modalities, and we'll talk then about the patients that are ineligible for a transplant. Please remember to subscribe to our newsletter. If you're in the myeloma community, please spread the news about our newsletter and our seminars, and anytime that any of you have any questions, and certainly suggestions about this series, we want to hear from you. There are no hands up now. Is there anybody online that has a question or wants to share anything?
Unmute yourselves. Helene
Oh,
has a question.
Helene Lalonde, what? Absolutely, go ahead. Just unmute yourself and let's hear from you.
Hi.
Hi.
Yeah, hi from Vancouver.
Hi.
Great job, you guys. I have a handful of questions, and I think they're one-word answers.
Okay.
One is who and how makes a decision on collecting enough stem cells for the potential second transplant? I know
Go,
I
Dr.
wasn't
Reese.
given the
Yeah.
option 12 years ago.
Yeah, and there has been some difference center by center, and the field's very much changing. Just so you know, there may be less second transplants done as newer immune treatments replace that option. But the the criteria for doing a second transplant is someone has a very long first remission. And then one has to compare with what other options. If someone is 69 and we want them to get the most out of a second transplant at relapse, and that implies that we want the first benefit to be at least 3 years, by then the person's going to be 72. So if someone is close to the upper age limit of a second transplant, which you shouldn't have been 12 years ago, we won't collect, not because we're trying to deny anything, but there's going to be other treatment options that are good. The other consideration is we run out of freezer space. It's a big problem because we most of the time don't do a second transplant, and we keep those stem cells, and we run out of freezer space. And these freezers are very expensive, very um, complex. There has to be an alarm system. And so there simply is not freezer space, believe it or not. And it's costly. I know in the US, we were not allowed to keep extra stem cells frozen when we can collect them the easiest time at the beginning, because it's at least $1,000 a year to keep them frozen under lock and key, and insurance wouldn't pay for it unless it was guaranteed we were going to use it. So,
Okay.
our center has tended to do it, but it wasn't done universally across Canada.
What was another one of your questions, Elaine?
The other one was just if PET scan is now part of the initial screening, because I just had mine like 2 weeks ago and I've never had it. And I know again, 12 years ago, probably didn't get
Yeah,
it.
it wasn't the data to support its use, which is required for funding, just wasn't there like it was for lymphoma or other cancers or Hodgkin's disease. Now, I can speak for Ontario. We are funded to do it at diagnosis,
Okay.
and we are funded to do it in smoldering myeloma and disease that doesn't make a lot of protein marker in the blood or urine. How else are you going to monitor the disease? But it's expensive.
Yeah.
But now it is finding its way in, and it's a good idea to have a baseline one
Mm-hmm.
because
And
it
Helen, have you had the chance to look at our previous seminars? Because we did one of the seminars that Dr. Reese and I did. We did talk about imaging and the PET scans and different scans. So if you haven't had the opportunity to see all the seminars, they are
Yeah.
accessible through CMRG.
Yeah. Yeah, I did, and it was
Okay,
helpful.
great.
Just what is the average age of diagnosis now?
it depends on how good your stats are for your country and what you're reporting, but it's around 65 to 70.
Okay. Is that going down? We just seem to have a lot of young members in our group.
It it the median age is not going down. There's
Okay.
more awareness of the diagnosis. I think it's not necessarily been shown that the disease is occurring younger, but again, lots of things are changing in our environment and
Yeah.
climate, and those stats need to be followed. But it's still a disease that is most frequent in that 65 to 70 age group. If you look at population statistics, the incidence is the highest in people like over 80.
Okay. Just last comment is just for the caregiver. I know again it was my husband, and we've had to fly my sister who's a nurse. It's a lot, and so I find there is lack of educating the caregiver. Like I don't think they know what they're up for. I mean,
Absolutely.
it's so anyway, I don't know if you guys do a better job at Princess Margaret, but VGH is just starting to kind of look into that. And then my
Well,
last comment is just fantastic that you said the medium overall survival is 13 years. Like, oh my God.
That's
Like
older
that's
treatment. I mean,
oh, fantastic.
yeah,
again, it's not long enough, but
Yeah.
we had no idea because there are people that say, Cyborg D is not that great, blah, blah, blah. Well, you look at the data
Yeah.
until things changed again. We were quite competitive as a country with what we had for any other first world country. But
Yeah.
now we have we have to get immunotherapy up front to see the next jump where that median survival is going to be 15 years. So, I mean, I was very, you know, relieved in many ways that our benchmark for that first CMRG analysis, which told us where we've been, was that amount of time. Now, there's discrepancies in there. There are people with very high risk disease, which is the minority, that that is a bit shorter, but it's still 8 or 9 years with the worst biologies.
Yeah.
So these are medians. So it gives us a starting point, and it was quite it's never satisfactory, but it was very comparable to what anyone else could do with other drugs until very recently. And now
Yeah.
we've got work to do.
Well, you've done a great job. I was in the clinical trial phase 3 of DARA. So today was my cycle 120. So
wow.
yeah.
Bravo.
So
Bravo.
anyway, I think our job as myeloma patients is just to stick around because there's a
Absolutely.
cure.
And Helen,
Thank
I
you.
hope that in May that you're online when my chat about symptom management and supportive care, because I want to hear from patients and families that have been through this, and what was done, what they felt where they felt they could have been better supported. Again, I'm not a physician, not a hematologist, not a scientist, but I think that the supporting the family members is so important. This is you know, a myeloma diagnosis certainly changes everything in a family. Is there, and I'm very cognizant of time. Is there anybody else online? Oh, hello, couple there that has no name that has their hand up. Thank you. Can you introduce yourselves if you might? Go ahead.
My name is Paul Levy.
Hi, Paul Levy.
Okay. I've been followed for about 7 years by a hematologist before we went to the clinic here in Ottawa,
Mhm.
and they confirmed. So in 2016, 15, 16, we started the treatment and so on. Yeah. So we went through an MRI to confirm that, plus the sample of the bone marrow, and now I could say I had made autologous transplant 16, which means now I have already 8 years on the go. For the next, if I want to have another next transplant, I will be 74 and above. So probably would not be eligible. So this is what worried me a bit. But on
Mhm.
the other hand, I know some of the phases are very difficult. It's challenging. I went for 5 years full-time work after the transplant, and I retired in 21.
Good for you.
Yeah.
Yeah, the whole issue of a second transplant relapse, you know, is is complicated by a lot of things. You know, people are getting older. What are the other treatments that are available, and what do you get with one treatment or another? And if they're close with a non-transplant, how do you decide? I mean, there are people that say, I never want another transplant, and there are people that say it was not that bad, I will take another transplant. So, and then there's the question of, you know, slipping in another transplant, does that affect what you get third, fourth, fifth line? So it's not as easy an answer as you'd think. Our philosophy has always been to keep options open, and then we'll deal with it at the time. But our freezer gets full. And there are times, you know, if we have to find out who will not have another transplant, because we actually have to discuss, you know, get back to the patient, you know, we don't have room, you're not going to have another transplant, we have to get rid of it because we're not going to get another freezer. And we do store many more extra stem cells than we give. And keep in mind that many centers in the US are simply not allowed to do it. So we have been, but we have to be responsible because we all know our resources are not indefinite. We have to make these decisions to ensure that we maintain our socialized system. So
I'm so pleased though, Paul, that you've done so very well. I mean, the fact that you went back to work full time for 5 years is remarkable in itself. So, you know, good for you, and you know, keep up the good work. Absolutely. And thank you for being here today.
There were some hiccup. Uh,
Sure.
the I didn't respond well to the maintenance. Revlimid was really some kind of a killer to me because I
Hmm.
end up with several pneumonia and then embolism. So we had to
Hmm.
stop it. So I've been going without any maintenance.
yeah,
Wow.
and you've gone 8 years. So it just shows, you know, we are not good yet at all about who will go 8 years without maintenance and who will go 1 year. We can say when you treat in those big trials 700 patients all together as a group, you know, the needle is moved and the group does better. But we have to do so much more to personalize it. MRD is not sufficient. It just tells you what's happening one day. We want to keep MRD going, and you have to take into account all the different biologies of myeloma, that some people's fish cytogenetics suggest it's going to be a more stubborn weed. It's going to want to come back faster, but does it? So I don't see how you can use MRD without a marker of disease biology, or maybe even looking at PET CTs, because, you know, it's not that simple. We're getting there, but that is the challenge. How do we can see these studies tell what we do as a group, but how do we individualize when we don't have a crystal ball for each patient? And my fear is always, once we lose control of the disease by dialing down or stopping treatment, what will happen with the next treatment?
Mm-hmm. Well, I'm going to knock wood, Paul, that you continue to be well and prove everybody wrong. And just you look like you look good. And I know that doesn't say tell the whole picture, but good for you. So again, being very cognizant of time, it's now 20 to 4. We still have 24 people online. We will close if there's no other burning questions that people have. Again, don't forget to check out the newsletter. Please go online to look back at the previous seminars that we've done. We want to hear from you. Is this a better time than over the dinner hour? Or, Dr. Reese and I will certainly make ourselves available for whatever time is best for the audience. And again, next month, Dr. Reese will talk about transplant ineligible patients along with new treatment modalities. And then in May, it'll be a less scientific talk, but more about the psychosocial challenges of myeloma and symptom management, and how we can best support our patients. So with that, I think we will say adieu for now. And again, thank you everybody for sticking with us. As Dr. Reese and I mentioned, we are both very passionate about this, and we could break these seminars into just little bites and talk forever. Please spread the word about the Canadian Myeloma Research Group. We are young, we are fairly new, and talk about it to other patients and people in the community. Go to the website for any information that you would
CMRG.ca.
Absolutely. CMRG.ca. And again, we Dr. Reese and I thank you very, very much for being with us today, and we look forward to many future seminars. And don't forget to fill out the evaluation for us. That would be wonderful.
And
I want to thank everybody for everything that has been done, and I'm very impressed. Thank you.
Thank you. Merci beaucoup. Thank you very much.
I won't embarrass you by my attempted French, but my kids went to bilingual preschool when we lived in Vancouver.
All right. Good night. Good afternoon. Good night, everybody. And we'll see you again. Bye-bye.
Bye-bye. Thank you.